That's good. I'm going to push record. And I'm making Trisha the host.
Have a clock ticking?
Yeah, I can hear it too.
I think it's coming from Senator French's audio.
There you go.
So what's wrong?
You have a clock on your desk maybe or something?
What's that?
You have a clock or something on your desk maybe? Doesn't it sound like that? Or?
Yeah.
You guys are live now. You're ready, Senator Kavanaugh. The public is here.
Okay, thank you, Alan, and welcome everyone to Senate Commerce. Welcome back from our hiatus, and hope everyone's been safe during this crazy time in our history in the state and the country. My name is Kevin Kavanaugh. I'm going to start off by welcome everyone, and then read a right to know script, and then we'll get everything started. Welcome, I am Senator Kevin Kavanaugh. Today we'll be hearing House Bill 1280 and Amendment 1298S. Before we get started, I'll read through a checklist to ensure that the meeting that we are holding is in compliance with the right to know law. As chair of the Commerce Committee, I find that due to the state of emergency declared by the governor as a result of COVID-19 pandemic, and in accordance with the governor's emergency order 12 pursuant to executive order 2020-04 and its extensions, this public body is authorized to meet electronically. Please note that there is no physical location to observe and listen contemporaneously to this meeting, which is authorized pursuant to the governor's emergency order. In accordance with the emergency order, I am confirming that 1, we are providing public access to this meeting by telephone with additional access possible by video and other electronic means. We are utilizing Zoom for this electronic meeting. All members of the committee and selected legislative staff have the ability to communicate contemporaneously in this meeting through this platform. Has access to contemporaneously watch and or listen to the meeting on Zoom, YouTube, and via phone by following the directions and links provided by the General Court website. 2, we have provided public notice of the necessary information for accessing the meeting in the Senate calendar. 3, we are providing a mechanism for the public to alert the public body during the meeting if there are problems with access. If there's a problem, please email remotesenate@leg.state.nh.us 03-271-3043. 4, in the event the public is unable to access the meeting, will be adjourned and rescheduled. 5, please note that all votes taken during this meeting shall be done by roll call vote. 6, finally, let's start the meeting by taking a roll call attendance. When each member states their presence, please also state where they are and if anyone else is in the room with you during this meeting, which is required by the right to know law, and I will call the roll. I was dreading saying all that. I'm glad it's done. So I'm Kevin Kavanaugh. I'm in my office in Manchester, and I am alone. Senator Morgan?
John Morgan. I am at home in Brentwood, and I'm alone.
Thank you. Senator Susie?
This is Donna Susie. I am at my home in Manchester, and I am alone.
Senator Morse?
This is Senator Morse. I'm in my office in Ashton, and I am alone.
Thank you. Senator French?
This is Senator French. I'm at my home lonely.
Thank you. I am going to be asking, before I introduce the prime sponsor of House Bill 1280 FN, I would like to let everyone know we do have a good amount of people to speak, and I want to limit the speaking time to 3 minutes per participant. And that is just to make sure everyone has the time to get to speak in it's a different format than we're used to. So if anyone could please respect that 3-minute time frame, I'd really appreciate that. So thank you. So I'd like to call the prime sponsor of HB 1280-FN, which is Representative Muscatel, and filling in for a representative is Senator Feltus. So Senator Feltus.
All right, it looks like Trisha is muted, so I'm going to move Senator Feltus over. Senator Feltus, you should be good to go.
Thank you very much, Mr. Chairman, members of the committee. For the record, Dan Feltus, State Senate, District 15, Concord, Hopkinton, Henniker, Warner, and Pennacook. Great to be before your committee again, Mr. Chairman, albeit virtually this time. So just wanted to present House Bill 1280 and speak briefly about the amendment that's forthcoming. I support the amendment forthcoming. It includes a number of key provisions about prescription drug affordability, including prescription drug wholesale importation programs similar to Vermont and Maine, but adapted uniquely to New Hampshire. It includes pharmacy benefit manager program alterations, which would help deal with excessive markups and better transparency in the prescription drug supply chain. The Transparency Board is important, the consumer protection is important, prior authorization, and the language on EpiPens. But the bulk of what I'm going to testify today in presentation of House Bill 1280 in lieu of Representative Muscatel is the insulin portion. And Mr. Chairman, members of the committee, as you well know, as we've discussed throughout the session, New Hampshire has amongst the highest healthcare costs in the nation. Highest premiums, highest copays, highest deductibles, and a principal driver of those highest costs in the nation is prescription drug costs. Amongst them is the cost of insulin, which the production of insulin has not gone up. The cost of insulin has not gone up in nearly 2 decades. However, the cost of insulin passed off to consumers has gone up more than 5-fold, including in New Hampshire. And all across New Hampshire, folks are struggling with prescription drug costs, including, you'll probably hear about it later on, a survey that approximately 20% of folks are rationing prescription drugs because of the cost of prescription drugs. And in rationing life-sustaining medication, in many cases, you end up in situations like going to the emergency room, and that spreads costs over the entire healthcare system. So this House Bill 1280 is critical to help our families, critical to help seniors afford needed insulin for diabetes. And so what does the bill do? Well, what it does is basically set a collective cap of $100 out of pocket for any 1 month for folks who need insulin. That is a reasonable approach. It's a reasonable approach to help allow folks afford life-sustaining medication, and it's an approach that other states have taken. It will help consumers, it will help families, it will help seniors, it will help families with children with diabetes. I would note that there is going to be some fair amount of discussion about some of the provisions, and then let me just briefly address some of those debates and discussions. First, there will be some suggestion to not make this effective immediately, but make it rather effective January 1, 2021. I think there'll be a suggestion of making the EpiPen provisions effective January 1, 2021 as well. Just to be clear, prescription drug affordability should start right now. It shouldn't have to wait till January 1, 2021. That being said, there'll be some arguments about plan years and that sort of thing that may make sense to the committee. I do think that affordability now outweighs administrative hassle of the insurance carriers, but the committee will make your determination about what you will do on that particular issue. Second, there will be an argument, I assume, to add to House Bill 1280 in the amendment forthcoming a transparency provision about the costs of production of insulin as a general proposition that makes sense. However, when it's been proposed in other states, including New Jersey, there's been worry about potential litigation surrounding that provision. So if this committee decides to move forward with that suggested amendment, I would strongly suggest that the committee consider including a severability clause that says that if there is a legal challenge related to that provision, that the balance of the provisions remain. Finally, on this, Mr. Chairman, members of the committee, there will be some discussion about the $100 and the language in that provision. Right now, House Bill 1280 is passed by the House and as worked on by Representative Muscatel, myself, advocates and others. It's a $100 a month collective cap. In other words, what that means is if you run out of insulin on day 26, day 27, or maybe a vial is lost or broken, day 1 through 29, it's still a $100 cap out of pocket for that month. And what we're seeing in some cases is people getting charged the full boat without, thousands of dollars if they need insulin before the end of that 30-day time frame. That's a major problem. And that's in part why some folks ration insulin. And so the collective cap, and you can see it, it says $100 of all insulin needed is in House Bill 1280. There may be a suggestion to move it to a $50 per covered prescription for 30 days. That would be fine if refills, in my view, if refills are not subject to cost sharing. If someone needs a refill before the 30 days is up, getting hit with another $50 or more on that refill, I think just adversely impacts families and adversely impacts situations where people may, lose a vial or they run out a few days earlier. They still need the insulin. They still need it. We can't be setting people up, for situations like under the current situation where some folks are rationing because they run out or they lose it or whatever. We need to protect people, and regardless of what the cap is, right now it's a collective cap, which affects everything. So if you need a refill, it's still under that $100. Last point on this, there are, most folks have 2, maybe more prescriptions of insulin. So if you even bump it to $50, you're still talking about $100 or more as a collective, setting aside the refill issue. If you have a pump, you have 1 prescription. So if you set it at $50, assuming you don't need a refill, that $50 for 30-day covered prescription would be beneficial to those folks. But the reality is, again, if you're going to deal with setting it only at the covered prescription for 30 days, regardless of the cap, you have to deal, in my view, respectfully, with the refill issue. Mr. Chairman, that's the balance of my testimony. I appreciate the committee's time and thank you for the opportunity to provide some input to the committee.
Thank
I'd
you,
be happy to
Senator.
answer your questions.
The committee, thank you, Senator. The committee members have any questions? Going once, anyone have any questions? Thank you, Senator.
Thank you, Mr. Chairman.
Presentation. Now, Trish, am I going to hand this over to you now?
Yes.
Trish will call the people that would like to testify, so thank you very much.
Sure. Okay, so first we have Senator Jeb Bradley. Senator Bradley, you should be able to unmute yourself now.
Good morning, everyone. Can you hear me?
Yes.
Beautiful. I have to say, I've said this on the hearings in front of Health and Human Services, all the staffers who are making, this remote technology possible, really excellent job. So I just have to say that it's not easy. You guys are working long and hard, and I appreciate it. So I would like to propose several, I think, small and technical changes to the comprehensive amendment that has been posted in the calendar. I have worked with Senator Soucy or had discussions with her as well as Senator Morse on this. I believe that if the committee adopts these changes, we'll be able to have bipartisan support for a really good bill that significantly moves the ball forward for a lot of different issues. I don't need to talk about some of the things like reimportation, the reverse auction where we agree on. So let me just touch base on the changes I would like to propose. I have emailed them to Senator Susi and Senator Morse. How they get distributed, I'm leaving that up to all the capable staffers to make sure that that happens. So Senator Feltz discussed the insulin provision. I think there could be agreement on the coverage of insulin, but let me just say this, it's somewhat unprecedented that the copays would be dropped to the level that's being proposed and a insurance policy not subject to any deductible. This is, if adopted, and I can support this, a significant step that will help people that need insulin. That being said, it's also, when we do things like this, there does drive costs in terms of the overall cost of the insurance policy. That being said, I think with the compromise that I'm going to propose, we ought to be all able to move forward on a bipartisan basis. Senator Feltz talked about what happens if somebody either loses their bottle or has to use more insulin. The problem with the amendment that's in the calendar is that prescriptions are not tied to any specific reimbursement mechanism. It's a $100 cap, but it's not tied to a prescription. So what I'd like to propose, and this is important for the insurance carriers, the PBMs and others that have to deal with reimbursement, it needs to be tied to an actual prescription. And so the thought is, because there's been testimony that the prime sponsor, Representative Muscatel, was aware of in the House, that there could be 2 prescriptions that the copay should be reduced from $100 in the calendar amendment to $50. And that's what the first thing that my amendment would propose. So if you have 2 prescriptions per month, you're at that overall $100 cap that the sponsors of the bill want. And to the extent that I know, virtually everybody would be covered by 2 or 1 prescription per month. So actually, this is a cost savings to the vast majority of people that only have 1 prescription. They'd be subject to a $50 copay, not $100. And if there are multiple prescriptions, they're still under the $100 amount. So the language that I'm proposing strikes the wording regardless of any amount, type, or number of insulins needed. I think Senator Feltz raised the issue of what happens if somebody has had a spike in their insulin usage during that 30-day period. And so what I would like to propose in all 4 sections of the bill is that language of the insulin piece, that language, regardless of any amount, type, or number of insulins needed, is struck and substituted for that the following sentence. And it would read, any needed refills within the 30-day time frame shall be subject to a maximum $50 copayment. So I know in my own situation, I take blood pressure medication. I don't wait until the last day to go refill my prescription. I usually go in several days before. I make sure I have the next 30-day supply, and it's easy to refill it. And so the point of this sentence is, if you are running short on day 25 or 26 or 27, whatever it is, you go and you get another 30-day supply, just like you had filled it previously, subject to the same maximum copayment of $50. There, again, under the amendment that I'm proposing, there'd be no subject to any deductible. So I think that by tying it to an actual prescription the $50 actually benefits the majority of people that use insulin and protects those that have multiple prescription, but it ties it back to an actual prescription. This should be the way I think that we proceed. Okay, so that's the first change that I would outline. The second change deals with sections 5 and 6 of the Commerce Committee amendment. This is Senate Bill 686, I believe, that was sponsored by Senator Rosenwald. And the language I'm proposing, which I believe you should have, would substitute all of the provisions that I'm providing for sections 5 and 6. So here's the rationale for it. A pharmacy benefit manager has what's called a Pharmacy and Therapeutics Committee, or otherwise known as a P&T committee. And it's supposed to be independent. It's made up of physicians and pharmacists and other clinicians. What they're supposed to do is develop a formulary utilizing clinical criteria, and then that comes first, but then they also are able to take into account cost considerations. So, for instance, if there are multiple drugs that have the same impact in terms of a palliative sense for consumers, but one is more costly than the other, this independent group of pharmacists, physicians, and clinicians can adjust the formula. So the goal in Senator Rosenwald's bill 686, as well as in the proposed amendment, is to make sure that there's not a conflict of interest. So the amendment that I'm proposing utilizes what's known as a Utilization Review Accreditation Commission. This is a not-for-profit entity. It's widely recognized. It's an independent accrediting organization that provides accreditation for PBMs. They make sure to minimize any conflict of interest, and they have these guidelines that need to be adhered to. So the language that I'm proposing for you is consistent with this Utilization Review and Accreditation Commission, and it does not require the costly procedure of forming a separate P&T committee specific for New Hampshire, which is actually going to have, I think, the unintended consequence of significantly raising the cost of prescriptions in New Hampshire. So I'd like to believe that this is an acceptable compromise that gets to the goal that Senator Rosenwald has expressed, but without the cost drivers, the cost increases that would come with this. The third change is something that Senator Susi, in our long conversations over the last couple of days, I neglected to, because I forgot, quite frankly, because we've been discussing so many different items, mention it to you. There is a provision in the bill that would require, I think it's in section 12, a prior authorization to be done within 48 hours. What I'd like to propose is that we change the 48 hours to 2 business days. The reason for that is that it just works consistently with how the prior authorizations work. Please remember that a couple of years ago, we adopted a provision in New Hampshire that you have 72 hours for emergency prescriptions before, and so somebody that needed a prescription would have access to the needed drugs within that 72 hours, even if there was no prior authorization given. So by having the 72 hours and moving to 2 business days, I think that is consistent with the intent of what we did a couple of years ago, but simplifies the process for the health benefit plan. The last change that I would propose is that, and Senator Feldt spoke to this, that we move the effective date sections for the EpiPen legislation, which was House Bill 1281, that's sections 13 through 18, and the insulin piece, House Bill 1280, to January 1, 2020. I think it would be wonderful to say, yes, let's just do it now, but providers negotiate plans with their members, whether it's an individual plan or whether it's a small business plan. And so they are bound by the terms and conditions of that plan for that calendar year. And so it would be, I think, inappropriate and unfair to force them to eat the cost of the change in law prior to their ability to change their plan. And so by virtue of the fact that, this would hopefully go into effect when signed into law, there'd be a 6-month lag. But the question is, can the legislature force the change in plan and the cost to the carriers before they have a chance to renegotiate that cost, either with the individual consumer or the small group? So those are the 4 changes. I'm happy to continue to work with the committee. Obviously, I believe that if we make these 4 changes, we are going to have a bipartisan bill that is a win-win for everybody involved. It really moves the ball forward, especially for people concerned about the cost of EpiPens and insulin, but it also incorporates the bipartisan agreement that we had on drug reimportation and the reverse auction. So, Mr. Chairman, thank you very much and happy to answer your questions.
Thank you for the testimony, Senator. Nice hearing from you. Are there any questions from the committee? Seeing none, thank you very much, Senator.
Thank you very much.
Tricia, I'll hand it off to you.
Okay, next, Senator, we have Brittany O'Donnell. And Ms. O'Donnell, you should be able to unmute.
I am. Can you hear me?
Yes, thank you.
Okay. Good morning, members of the committee. I first of all, in listening to the senators that have gone before me, would like to address changing it from now effective immediately to January 1st, and just say that there have been states, Utah actually just passed a copay cap that is effective immediately. I would really urge you to consider doing the same, especially given the unemployment rate and the growing uninsured rate right now. Other than that, some of what you're talking about in terms of there being a lapse if a vial of insulin is broken or lost or something happens to it, it's almost an emergency bill, which New Hampshire does have an emergency bill on record, but it does not necessarily, it's a little vague, especially in terms of what prescriptions and how frequently you can use it. In terms of insulin, there's a lot of bills in other states called Alex Bill, which would allow for these copay caps, but there's also bills that help to help a diabetic in case of an emergency. So if they break or lose a vial of insulin and it's a holiday weekend, they don't necessarily have the time. And if their prescription isn't ready yet, the pharmacy will turn them away. There are laws on the book that allow someone to go into a pharmacy that they've been going to. So if I go to CVS, I could walk into CVS and say, I really need a vial, and it would allow me to refill that prescription or at least get a vial to get me through on good faith, because I have had a valid prescription. They can tell that I'm a diabetic and I use that insulin. Those issues being addressed, I would love to, I prepared a testimony and I sent it over last night, and I would love to read that to you. My name is Brittany O'Donnell. I am the New Hampshire chapter leader for T International, which is a global grassroots organization. They fight for the accessibility and affordability of insulin. I'm 31 years old, and this year I've celebrated 30 years with diabetes. I spent a good portion of my life taking for granted that I never had to worry about whether I would have to choose to eat or purchase the medication I needed to live. My parents raised me to believe that I would never have to live my life with diabetes. I would live it in spite of diabetes. I believe that's part of the reason they never talked about how much it actually costs to keep me alive and healthy. It would be contradictory to tell someone that they can achieve anything if only they can afford their medication. I turned 26 at the end of March, and on April 1st, this was 2015, I had to jump onto my health insurance at work. I had refilled all of my insulin pump supplies prior to this because I knew I would go from paying $900 or 20% to having to meet a $5,000 deductible. This, by the way, took me well over a year to pay off. It has always been a well-known fact that insulin pumps and continuous glucose monitors are considered luxury items in the diabetic community. What was not a well-known fact until people started dying in the community and we became outraged is that insulin has also become a luxury item. Between 1996 and today, the price has gone up 1,200%, so there have been no changes made to the insulin itself. I had never refilled my insulin before the insurance change. After all, it had never cost me more than $40. The first time I went to refill my insulin, I walked up to the pharmacist with the same cheerful demeanor I'd had for years. That smile was quickly gone away and replaced by tears when she told me that my 1 month supply would be over $350. My new insurance did not cover name brand insulin until I had met my deductible. I asked what the generic was, and she gave me a look of pity as she told me there wasn't one. There would actually be no generic form of insulin until 2019, and even that's not readily available to people. I told her I couldn't afford it as the line built up behind me. I purchased one vial, enough to last me 2 weeks, and left with information to look into a coupon to bring the copay down. In the next 2 weeks, I would draw insulin out of my pump when it said I had none left. I would find old vials around the house that had a few units left, not knowing how old they were or if it were expired. I waited for my blood sugar to go over 250 before I would correct it because I didn't want to waste the insulin if it would come down on its own. Your blood sugar is supposed to be between 80 and 120. I would choose my meals based on how much insulin I was willing to use, often opting for a salad. I rationed every way that I could. 2 weeks later, when I had finally run out, I went back with a coupon that brought the other 2 vials down to $100. Using that coupon meant that it would not go against the deductible I had to meet, and I could only use it once every 30 days. Given I had picked up 1 vial at full retail, I had unknowingly put myself into a cycle to have to spend full retail on at least 1 vial every time.
Sorry to interrupt, Senator Kavanaugh. That's been 3 minutes.
Oh, sorry.
Thank you, Brittany. We're trying to keep everyone at 3 minutes. If you could wrap it up and give me a couple more seconds, if that's okay.
Sure. So I never told anyone about this until Alex Smith died in Minneapolis in 2017. It got me involved in this, and a lot of states have really started working on copay caps around the same time that we did. I think it's absolutely imperative that we not only pass it here in New Hampshire, but pass it now, especially with all the current events. January 1st might have been an acceptable time or one that we could agree on a few months ago, but with everyone losing their jobs and losing their health insurance, I think it would be unreasonable to let people go another 6 months knowing that there are so many who aren't protected.
Thank you, Brittany. I appreciate that and appreciate you sharing your story with us. Are there any questions from the committee? Seeing none. Thank you, Brittany, for your testimony.
Thank you.
Thank you. Trish, next.
Okay, next, Senator, we have Representative Ed Butler. Oh, sorry, hold on. Okay, Representative, you should be able to unmute.
Can you hear me?
Yes, thank you.
Excellent, thank you. Thank you for taking my testimony. Unfortunately, I did not understand and learn, did not pay attention to the calendar, although I know that it just came out in the past short period of time, that this omnibus bill would be coming for hearings today. Hearing that there are amendments coming forward, I am assuming that your committee will be meeting again in order to look at whatever changes you have agreed to include in the bill. And I would ask that you include those of us in the House who have participated in these pieces of legislation that have come before you. It's a strange process that we're going through, and I know we all know that. To put together this omnibus bill to make the changes that are being recommended to you, many of which those that I've heard this morning so far sound reasonable and could improve the bills. It is going to come back to the House, and you're going to expect that we are going to concur with whatever changes you make. In order to do that, it seems to me that it makes only good sense to include some of us in the House who have been involved in these bills to agree, work with you and agree to the final product. I hope that that will be possible, and encourage that outreach happen, and am certainly available to work with you. It would be great also just to have the listing of the bill numbers that are being included in this omnibus. I heard SB 686, I know 1280, I know 1281, but it would be great just to be able to refer back to the original bills. So if we could have that listing of bill numbers, that would be very useful. I hope that we can work to create a bill that you are excited to support and which the House can comfortably concur on. Thank you.
Thank you, Representative, for your testimony. Are there any questions from the committee? Seeing none, thank you, Representative. Tricia.
Thank you.
Next testimony.
Yes, so next, Senator, we have Stephen Habby. Let me get him. Mr. Habby, you should be able to unmute. There you go.
Great, thank you. Chairman Kavanaugh, members of the committee, thank you for the opportunity to testify. My name is Stephen Hobby. I'm speaking on behalf of the American Diabetes Association to convey our support for House 1280 to cap insulin costs. New Hampshire, like the rest of the country, has experienced a diabetes epidemic. We estimate 121,000 people in New Hampshire have diabetes, or about 10% of the adult population. And every year, another 5,000 people are diagnosed with diabetes. Many people with diabetes need insulin to live and to avoid devastating complications that can result in blindness, kidney failure, lower limb amputation, heart attack, stroke, and possibly death. But too often, people with diabetes are struggling to afford the insulin their doctor has prescribed. A Yale survey found 1 out of 4 insulin users were rationing their insulin, either taking less than the dose they needed or skipping doses. This jeopardizes their health. People with diabetes may have trouble paying for insulin at list price before meeting their plan's deductible. They may also struggle with costs after meeting their deductible. House 1280 would help people in state-regulated health plans by capping the cost they're paying for their insulin to no more than $100 a month, even if they need more than one type of insulin to manage their diabetes. The bill also ensures that insulin would cost them no more than $100 a month prior to meeting their deductible. By ensuring that insulin is affordable, people with diabetes are better positioned to manage their glucose levels to stay healthy and productive. By keeping insulin affordable, we can help keep people with diabetes out of the ER and out of the hospital and away from expensive and potentially disabling or deadly complications. Bills like this one are being passed around the country to address insulin affordability, and 8 states have already passed similar legislation this year. On behalf of people with diabetes, we urge your support for House 1280 to help make insulin more affordable. Thank you.
Thank you, Mr. Habby, for your testimony. Are there any questions from the committee? Seeing none, thank you, sir.
Thank
you.
Okay, Senator, next we have Donald Funstein, and I will pull him up right now. Mr. Funstein, I'm sorry if I'm mispronouncing your name, but you should be able to unmute now.
Thank you. Yes, hi, good morning. I am Don Funstein or Funstein, it doesn't really matter. Thank you, Mr. Chairman, Madam President. With my colleague Heidi Kroll, who will speak a little bit later on different aspects of the bill, we represent AHIP. AHIP wants everybody to have affordable access to necessary prescription drugs. We also acknowledge, and we would expect, frankly, that policymakers respond to real human needs with the tools they have available to them. We understand that this amendment is your effort at doing so. We would simply ask that you would consider seriously adopting the proposal that was explained to you by Senator Bradley a few minutes ago. It's very important that the cap on copayments be tied to a prescription, not a time period. We think it's so important, in fact, that although it is originally set as $100 per month, and we had proposed $50 per prescription, we would propose $35 per prescription. Because the mechanism of being on a prescription is really, really important in terms of how the healthcare financing system is set up. Now on refills, yes, people need their insulin refilled. I would caution against a mechanism that creates an incentive for human behavior, however, to avoid a recap by seeking a refill early. For instance, if you go in on day 28, or you go in on the first day of the month, you should be subject to the same $50 maximum copay per prescription. Otherwise, you're creating an incentive to essentially avoid the cap by filling early. Now, we would be more than happy to have the opportunity to work with the advocates on a solution that works for everybody. There clearly is a solution here. And the emergency provision that you heard about earlier, maybe it needs to be tweaked a little bit to work in these circumstances. But we would again ask you to consider seriously the points Senator Bradley made. In attempting to wrap up with my last 90 seconds, I hope, the issue of insulin affordability is not an insurance controlled crisis. It's a pricing crisis. And the copay cap actually increases the manufacturer's leverage in raising prices. Now, we understand you need to work with—
Sorry to interrupt, Senator Kavanaugh, that's 3 minutes.
And with that, I would simply thank you and encourage you to also adopt the transparency language. Thank you very much, Mr. Chairman.
Thank you, sir, for wrapping that up. I really do appreciate that. Are there any questions for this speaker from the committee members?
May I ask one, Mr. Chairman?
Yes, Senator Susi.
Yes. Attorney Funstein, could you just address a little more the issue of someone, my understanding, and it's certainly not with a great deal of depth or any experience regarding the use of insulin, but my understanding is that insulin is something that is not needed on as consistent a basis. So for example, if I'm given a prescription for some type of pill, it's every so many hours and I can measure my dosage. Insulin, my understanding, is much harder because of the inconsistency that people experience, the symptoms that they need to use the insulin for. So for those who need more insulin in one particular month than they do the other, I guess I don't quite understand your issue of people trying to get more insulin in advance of what they need and trying to skirt the system or create behaviors that skirt the system. My understanding is that it's not the behavior of the individual, but the behavior of the condition that requires them to need it on sometimes a less than 30-day basis. So I wonder if you could just address that a bit more.
Sure. Unfortunately, I wish my wife of 40 years was with me here at the moment, since she's a pharmacist and I'm sure could do a better job than me at answering your question. But basically, all we are saying is that when you look at attempting to provide another wonderful benefit for people that need it, that you do it in a way that uses a mechanism that doesn't create an incentive to actually avoid the mechanism. Now, we're not suggesting people get up in the morning and think about, well, how can I avoid my copay? But human nature is human nature, and you'll see that occur unless you have it apply. Now, if we're talking about a 2 or 3 day supply, then I would suggest we look at tweaking this emergency provision, which is already in law, and that would seem to address that circumstance. What we're saying is, don't use a mechanism that changes the entire incentive within the system that you're trying to develop for people.
Thank you.
Thank you. Are there any more questions from the committee? Seeing none, thank you, sir.
Thank you.
Tricia?
Okay, Senator Kavanaugh. Next, we have Holly Stevens. Holly, you should be able to, thank you.
Can you hear me?
Yes, thank you.
Hello, I'm Holly Stevens. I'm the Health Policy Coordinator at New Futures. I appreciate the opportunity to testify in front of you today virtually, and appreciate all you've done in order to make this possible and to be able to finish the session. I know that you've heard me speak about prescription drugs ad nauseum, so I will try to keep this as brief as possible and just highlight that, now in the face of the COVID-19 pandemic, that this legislation is more important than ever. And that, as you know, people with underlying medical conditions are at a higher risk of complications, up to and including death, if they contract the virus. These conditions include, but are not limited to, asthma, diabetes, cancer, HIV, cystic fibrosis, and heart and kidney disease. The U.S. Center for Disease Control and Prevention is reinforcing the need for people in this high-risk category to stay on their medications to minimize the risk of complications. Many of the medications used to treat these illnesses are extremely expensive, and this amendment will do a lot in order to try to get a hold and bring those prices down. Also, according to the American Diabetes Association, approximately 130,800 people in New Hampshire, which is 11%, have diabetes. And many of them have to skip doses, ration their medication, and making them more susceptible to complications if they were to contract COVID-19, simply because they could not afford their insulin. And so with that, with the Drug Affordability Board and with the reimportation program, I think that this is very important legislation. And I understand the insurance companies. I didn't know about Senator Bradley's suggested amendment until just now. And I understand the insurance companies' concern in wanting to line this up with the plan year. My only concern with that is right now we're in the middle of a pandemic that's not going away. And if people cannot afford their insulin, they may die. So I don't know if there can be some compromise on, until this pandemic is over. It's just something to think about, and it's something that I hope that Senator Bradley and Senator Moore, Senator French will also think about really hard before agreeing to push this deadline out for the insulin part in particular. And with that, I will wrap up my testimony, and I'll take any questions that you may have.
Thank you, Ms. Stevens. Are there any questions from the committee? Seeing none, thank you. Trish, next speaker.
Yes, Senator, we have 3 more speakers for the bill, and the next speaker is Kenneth Norton. Mr. Norton, you should be able to unmute now.
Hi, can you hear me?
Yes, thank you.
Great. Thank you, committee members. My name is Ken Norton, and I'm the Executive Director of NAMI New Hampshire, the National Alliance on Mental Illness. And I also have family members with serious mental illness and co-occurring substance use disorders. Appropriate medication therapy is a key component in the recovery process for many people managing the symptoms of mental illness. And the National Institute of Mental Health has stated, and I think we can all agree, that our bodies are different and we react to and metabolize medications differently. Although two people may carry the same diagnosis, there's a good possibility they would not be on the same medication or dosage. And further complicating these matters is that with mental illness, some medications such as antidepressants can take 4 to 6 weeks to demonstrate effectiveness. The high cost of prescription drugs has resulted in the creation of medication formularies, or sometimes tiers, which for people with mental illness often require individuals to fail several specific medications before they'll be considered for a non-formulary or higher priced tiered drug. It should be noted that this higher priced medications are typically the newer medications with better demonstrated outcomes and less side effects. This has resulted in many people determining which healthcare plan they select based on the availability of and the copayment or out-of-pocket expenses or one or two medications. Think about that for a second. Selecting a plan for your overall health based on the cost or availability of one medication, rather than a decision being made together by a prescriber and a patient about what is likely the most effective medications for their condition. Decisions are being made based on cost and availability and formulas. Prescribers of a medication such as a doctor or healthcare provider should be providing what they think are the most effective treatment available. And these formularies and accompanying tiered copays can seriously delay effective treatment and is also dehumanizing. People with mental illness have long faced discriminatory practices by health insurance providers. In 2015, NAMI National issued a report entitled The Long Road Ahead, Achieving True Parity in Mental Health and Substance Use Care. The report's based on survey responses from 3,000 individuals and supplemented with an analysis of 84 health plans in 15 states. The report provides strong evidence that consumers continue to face more significant barriers in accessing psychiatric or mental health care than they do in accessing medical specialty or primary care. And specifically, the report details how psychiatric medications are more frequently placed on the higher tier drug formularies, making them less accessible and with higher consumer costs than medications for other medical conditions. Mental health parity has not yet been achieved. And I'll forward the link to you, pages 6 to 9, which deal in that report with the topic of access to prescription drugs. People should not have to make a choice about buying food over medications or titrating medications or vice versa.
I'm sorry to interrupt. Senator Kavanaugh, that's 3 minutes.
Great. On behalf of NAMI New Hampshire, I urge you to vote 1280 with its amendments as ought to pass. Thanks for your time and consideration.
Thank you, Mr. Norton, for wrapping that up. I appreciate it. Are there any questions from the committee? Seeing none, thank you, sir.
You're welcome. Thank you all.
Thank you. Tricia, if you could call the next speaker, please.
Next, we have Elizabeth Kennett. Ms. Kennett, you should be able to unmute now.
Good morning, everyone. I would like to thank the committee for being able to discuss House Bill 1280 in regard to the affordability of insulin. I'm a nurse and a certified diabetes care and education specialist with over 31 years of experience as a manager and an inpatient and outpatient educator in the field of diabetes self-management education. During my career as an educator, I saw frequent admissions for a serious condition called diabetic ketoacidosis, or DKA. DKA results when a person with type 1 diabetes who requires insulin for life goes without insulin. It can happen when there's not enough insulin to cover the body's needs, as during a serious infection. DKA is a complication of diabetes, a very serious complication of diabetes, and quickly result in death without treatment. Sometimes it can be treated in an emergency room, and sometimes it requires an ICU stay. Why does DKA happen? It happens because Individuals with type 1 diabetes and others with diabetes cannot afford the outrageous out-of-pocket expenses for insulin. I'd like to give a couple of examples of patients in the experience of my colleagues. One is a 23-year-old. Her name is Mary. Name change, obviously. She lives in the Seacoast area. She's got type 1 diabetes. She's been on her own since she's 16 years old. She works and she has insurance. She also has the responsibility of raising her younger brothers, who she's trying to keep out of foster care. She can't afford the amount of insulin that she needs to keep her diabetes under control and runs the constant risk of going into DKA. There are many that have similar scenarios. They own insulin pumps and may even be able to get the pump supplies to test their blood sugar. They have the technology and they have the knowledge to keep their diabetes under control, but they can't afford to buy the insulin to put in their insulin pumps. It's kind of like having a very nice car, but not being able to afford the gas to put in the car. Without the gas, the car stops. Without insulin, the body stops. We go into crisis. Others with type 2 diabetes may require insulin to keep their diabetes under control, a goal that all healthcare providers have for their patients. But especially during this pandemic that we're experiencing, it's critically important that people have access to the amount of insulin that they need and the types of insulin that they need to keep their diabetes under control, which can affect the immune system. People with diabetes that is out of control, it seriously impacts the immune system and increases the susceptibility to all different kinds of diseases. Within New Hampshire, we have many individuals who have dire financial circumstances. If lucky, they've kept their insurance, but if it was a 2-individual family, a spouse and partner, okay, and one of them loses their job.
That's 3 minutes.
Thank you. Just want to wrap up very quickly. We want to make sure that individuals have the amount of insulin that they need, even in this very dire epidemic situation we're going through. Thank you.
Thank you, Ms. Kennett. Are there any questions from the committee? Seeing none, thank you for your testimony. Tricia, next speaker, please. Oh, you're on mute, Trish.
Okay, the last speaker I have on the bill is Beverly Cotton. Ms. Cotton, you should be able to speak now. Unmute yourself. Ms. Cotton, are you there? Hello, can you hear us?
We saw you come off mute. We can't hear you.
Ms. Cotton, are you there? You're able to speak now. Okay. Ms. Cotton, if you can get your audio going, we can call on you again if you just want to digitally raise your hand. Thank you. Okay, Senator, that is all I had for the bill to speak.
Okay, so we'll give, first of all, I'd like to see if there's any more people from the public that are wishing to speak. And maybe we'll just give it a couple moments in case someone wants to raise their hand, or you can also access the chat room and let us know you want to speak. And also if Ms. Cotton is still there or having problems, we'll just give it a couple moments.
Sure. I do see Ms. Cotton is signed in twice, so I'm going to try to. Ms. Cotton, are you there now? Nope. Okay. And I do not see any hands raised right now. Oh, I do have a hand raised, Senator Kavanaugh. I have Todd Fahey who would like to speak. Mr. Fahey, you should be able to unmute now.
Hi, Todd Fahey. Can you hear me okay?
Yes, thank you.
Great. Pardon me. You may, perhaps if you cannot get Ms. Cotton to speak, perhaps Doug McNutt could speak on her behalf. She is with AARP. She's a volunteer and a person with specialized experience. If you cannot, I suspect we can maybe just get to her testimony a little later. Thank you.
Okay. Let's see. Mr. McNutt is on the list. Does he want to speak? He can raise his hand. Okay, he's there. So Senator Kavanaugh, I have Mr. McNutt.
Okay, thank you.
Mr. McNutt, you should be able to unmute yourself.
Yes, thank you very much. Thank you, committee members. My name is Doug McNutt. I'm the Associate State Director for Advocacy for AARP. And I know that what Bev Cotton would have liked to have spoken to you about is a story of a family that she is familiar with that is struggling very difficultly with getting insulin that is necessary. And he's an engineer, and because of the family situation and the inability to get coverage that is consistent, it's been a very difficult struggle for them. So this kind of legislation would be extremely helpful for that family and for that person. And so I thank the committee for the work that you're doing. I thank you for all the testimony today. And I also thank you for the amendment that you've been able to put together. And we look forward to moving forward on these issues. Thank you so much.
Thank you, Mr. McNutt. Are there any questions from the committee? Seeing none, thank you. And if Ms. Cotton is still on, we can you can send in written testimony. We can make sure that it gets to all the committee members if you're having difficulty with the audio or video. So, Tricia, are there any more?
I do not see any more hands raised, Senator, for the bill.
Okay. All right. Well, I want to thank anyone. Is there any questions from the committee before we start the public hearing on House Bill 280 FN? Seeing none, I'd like to close public hearing for House Bill 1280 FN. Do we need a roll for that, or is it? Can we just close it? Just close it. Okay, great. All right. What we'll do, we are going to start Amendment 1298S, but I just want to, if the staff needs a moment, just let me know. We can take a minute. You guys get ready to go?
We're good.
Good. Aaron, you good? Yep. Okay, great. Cam, you good? Okay. I'd like to open the public hearing on, excuse me, Amendment 1298 SN. And do we have someone that's going to present this? I do have something if we don't.
I do not see.
Okay. Then I'm up.
Okay.
Thank you.
Mm-hmm.
Excuse me? Sorry. Amendment 1298 SN is composed of Senate Bill 685 FN, Senate Bill 686 FN, Senate Bill 687 FN, Senate Bill 688 FN, Senate Bill 691, and House Bill 1281 FN. Together, this amendment aims to create a prescription drug importation program, establish a reverse PBM auction process, create a prescription drug affordability board, lower the cost of generic drugs, require prior authorizations for formulary covered prescription drugs to be approved within 48 hours, and require insurance coverage for epinephrine? Sorry, auto injectors. Sorry about that. And are there any questions? I would like to hope there's not. Seeing none, if we could move on, Trish, to the public speakers.
Yes.
Thank you.
Okay. We have first on our list here.
And sorry, Trish, I would just remind everyone, how many speakers do we have?
We have now it is 13 speakers.
If I could just remind the public that we're trying to keep everyone to the 3-minute time frame, just to give everyone the chance for everyone to say what they want to say. So thank you.
Okay, sorry about that. Okay. We have Tyler Brannon who would like to speak. Mr. Brannon, you should be able to speak now.
Good morning. Tyler Brannon, Director of Health Economics with the New Hampshire Insurance Department. And I'm going to stick to the 3 minutes as best I can and go directly to the things that we're most concerned with. We don't take a position on a bill, and indeed, we don't have a position for most of the contents in the amendment. So we're neutral on the Drug Affordability Board, the cost sharing piece for insulin, the coverage for the epi injectors, and a number of the other provisions. Some of these provisions may impact premiums, but that's a policy decision. We're always happy to provide analytic support for the legislature to better inform you about the costs associated with any legislation, and that's a normal course of business. Our main concern with the amendment is actually just one section, that section 19, which begins on page 26, line 7. This modifies the PBM chapter that was created last year, and I was going to say more about the complexity of where all the different regulations as they relate to PBMs are, but this particular chapter applies to PBMs that are operating and performing services for a number of different companies. So it's actually not PBMs that are servicing just one carrier, and it's not PBMs that are serving self-funded employers, but it is a section of the market, a section of coverage. For a number of
Oh, Mr. Brannon, your audio went out.
Mr. Brannon, we lost you.
Okay, Mr. Brannon, if you'd like to reconnect, and I can call on you again. Okay.
Why don't we move on, Trish, and then if Mr.
Yes.
raises his hand or in the chat room, we can come back to him.
Sure. Okay. So next, we have Todd Fahey, who would like to speak to the amendment. Mr. Fahey, you should be able to speak now.
Good morning. Thank you. Good morning, Mr. Chair, committee members. Thanks for hearing from me again. I trust you can all hear me now. And forgive me for doing all this, but I'll keep my comment short. Most of you folks have seen this before. I've testified to it, and I am the state director of AARP New Hampshire. We have 220,000 members in New Hampshire. We have dozens of volunteers on the line this morning who, if you could see them, I trust you probably can't, but are in support of this as well. One of whom would be Bev Cotton. So there's a few, I guess, I would start by saying that this is obviously legislation certainly relative to importation and transparency that you've seen before and that you've supported before. And for that, we thank you. It's been a good bipartisan bill. It started off that way, and it seems like it's continuing that way. I would say it was time for this legislation pre-pandemic. It's time for this legislation now, given what's going on. And let me just give you a few reasons as to why, and otherwise I would rely upon the written testimony that I submitted yesterday. So a few things, and you've heard it before. We're one of the oldest states in the nation, and the average older American typically takes 4.5 prescription drugs on a chronic basis. So the problem is acute and real here. The average annual cost of prescription drug treatment increased by 57.8% between 2012 and 2017. But at the same time, the annual income for Granite Staters increased only 13.2%. So obviously there's a huge disconnect between inflationary costs and wage increases. In 2017, a real compelling number that this committee, I think, has heard before, and I would ask it to consider again as you think about this, this bill, 22% of Granite Staters, 22% stop taking medication as prescribed due to cost. Again, the problem is real here. Granite Staters have labored under the cost of high drug prices for years and years, and it really is time to start thoughtfully solving this problem. And again, we are very heartened and frankly, very proud of the work that we've done in New Hampshire on this with all of you and how this has been thoughtfully considered. Finally, the state solution to allow FDA-approved drug importation is not new. This has been happening in other places. It's happened to our neighbors on both sides. Vermont and Maine have thought that it's time to take a look at this. And while we don't share a lot in common necessarily with those states, except for our common borders, we certainly share an older population. And finally, before I conclude, I'll just say the onset of the COVID-19 pandemic, thousands of Granite Staters have lost their jobs. Back to my point, we needed this before this being reform. We needed this kind of policy reform before. We surely need it now. Thousands have lost their jobs and are feeling or may soon feel tremendous economic pressure. I'm hoping they don't, but as we all know, it's likely we will. So it is time for this work. We would certainly ask for your support, and thank you for the prior support you've given to elements of this legislation. And I'll take any questions. Thank you, Mr. Chairman.
Thank you, Mr. Fahey. Are there any questions from the committee? Seeing none, thank you, sir.
Thank you.
Tricia, if you could call the next speaker, please.
Yes, next we have Donald Funstein. I think I said it right this time. Mr. Funstein, you should be able to talk now.
I would yield my time.
Okay.
Thank you, sir. Tricia, the next speaker, please.
Yes, next we have Holly Stevens. Ms. Stevens, you should be able to unmute.
Chairman and committee members, thank you again for the opportunity to speak. I will be extremely brief this time around because I think I covered most of my testimony when we were discussing the underlying bill. But I did just want to point out that with the Drug Affordability Board and the importation program, which has the reverse auction in it, that provides the state an opportunity to have some significant savings in general fund. And given the fact that it's been stretched so thin right now because of the COVID pandemic, it's certainly worthwhile not only to pass this amendment for the benefits of the residents that need prescription medications, but for all the residents of New Hampshire who are going to need other programs continued that are funded by state funds. And again, Holly Stevens, New Futures, we do policy and advocacy work on the behalf of all New Hampshire residents. That concludes my testimony. Urge you to pass this legislation. And with that, I'll take any questions.
Thank you, Ms. Stevens. Are there any questions from the committee? Seeing none, thank you. Trish, can you call the next speaker, please?
Yes, so next we have Tyler Brannon back again. Mr. Brannon, you should be able to speak now.
Great, thank you. My apologies. The screenshot just kind of froze, so I'm not sure what happened to my connection. But I was about to address the section 19, the only part that we actually have a position in substantial concern with, and this has to do with the patient cost sharing for low-cost drugs. It would change the definition that exists in insurance rule as it relates to contracted co-payment. So the debate is about, or what it would do is, for example, a $25 copay, $20 drug charge, $10 fee schedule amount that says the pharmacy will get $10 for the drug. And the question is, what do you think the patient should pay? Well, the rule requires PBMs and carriers to calculate the cost sharing amount at $10 and the patient to pay $10. There have been some interest by the pharmacy community to get the drug charge, which is $20. But if we change this definition, it actually won't change what the pharmacy ends up with, but it will result in the patient paying more. The patient may end up paying $20. The PBM or the carrier could claw back that overpayment and adjust future payments to the pharmacy, but those monies would not make their way back to the patient. So this would directly conflict with what's in our regulation at the moment. It would also directly conflict with an earlier section of this amendment. So we don't necessarily have a policy position, but this is something that would be anti-consumer and create a technical challenge for the department. So we would strongly encourage you to strike that section 19. But as I mentioned earlier, we otherwise do not have a position on the bill or the amendment. So I'm going to stop there and take any questions you have.
Thank you, sir. Are there any questions from the committee? Seeing none, thank you. And Tricia, if you could call the next speaker, please.
Yes, next, Senator Kavanaugh, we have Heidi Kroll. Ms. Kroll, you should be able to speak now.
Good morning, Mr. Chairman and members of the committee. Are you able to hear me?
Yes.
Great, wonderful. Thank you for the opportunity to testify. My name is Heidi Kroll. I work at Gallagher, Callahan, and Gartrell, and I'm testifying today on behalf of AHIP, America's Health Insurance Plans. I will not be duplicating anything that you heard from my colleague, Attorney Funstein earlier, but I would say that we certainly welcome the opportunity to work further with committee members and any interested stakeholders on any of the sections of the bill, certainly including the insulin section as well as any others. Would certainly welcome that opportunity to move the ball forward. I want to address very briefly just a few sections in the bill. Section 12, this is a section relative to prior authorization. We are seeking just a few minor changes, and these are consistent with the amendment that Senator Bradley spoke to this morning, and we do support the amendment he addressed. I should say that on this one, right prior to the closure of the legislature, AHIP and some plans met with the Hospital Association, the Medical Society, and Dartmouth Hitchcock, and we came to some tentative agreements. Of course, we were never able to close the loop, but these seemed pretty non-controversial. But at any rate, changing 48 hours to 2 business days, and also after, in the language, when a provider has submitted a request with a complete clinical rationale. That clause with a complete clinical rationale is found in other statutes that we have relative to prior authorizations. It's pretty standard. And so this was, I would kind of put this in the category of housekeeping. Also, an effective date of January 1st of 2021 would be appropriate, we believe, for this section. And again, just keeping in mind that we do have a law on New Hampshire books that a 72-hour supply of a prescription may be obtained while a prior authorization is pending. So that would certainly provide the consumer protection that I think we all would want. The second section that I wanted to address is section 13 through 18. This is the epinephrine sections. Again, just making a note about the the effective date. Again, looking for January 1st of 2021. Carriers would need to make system changes. New mandates are typically aligned with the start of a new plan year, which is the calendar year. At the very least, we would need 60 days to implement system changes. But again, being consistent with what we typically do with other new mandates, January 1st would be helpful. I would also just call the committee's attention to the fact that
I'm sorry to interrupt. Senator Kavanaugh, that's 3 minutes.
All right, I'll wrap it up very quickly. Thank you.
Great, thank you, Ms. Kroll.
Epinephrine sections came from House Bill 1281, and there is a fiscal note to that bill, and I just wanted to call that to the committee's attention because it does note that there will be costs to the state. That's explained in the fiscal note, so I won't go into it, but I did want to call that to the committee's attention in case you were not aware. And my final comment is to simply say that we agree with the testimony of the insurance department given by Tyler Brannon. We would support striking section 19 in the interest of protecting consumers and ensuring they get the lowest price when they go to the pharmacy counter. With that, I'd be happy to take any questions, and I thank you for your time.
Thank you for your testimony. Are there any questions from the committee? Seeing none, thank you.
Thank you.
Tricia, if you call the next speaker, please.
Yes, next we have Kenneth Norton. Mr. Norton, you should be able to unmute now.
Thank you. I will yield my time. My comments were based on the previous comments and testimony that I gave. Thank you all.
Thank you, sir. Tricia, you can call the next speaker, please.
Okay. Next we have Curtis Berry. Mr. Barry, you should be able to speak now.
Good morning.
Good morning.
Thank you, Mr. Chair, members of the committee. I am Curtis Barry here on behalf of the Pharmaceutical Care Management Association, or known as PCMA, which is the National Trade Association for the Pharmacy Benefit Manager Industry, also commonly known as PBMs. And my testimony relates to sections 5 and 6 of Amendment 1298, which were contained in Senate Bill 686. I'd like to point out at the outset that very often in these discussions on legislation, lost in a discussion is who's paying the premium, whether it's a large business who self-insures or small businesses who may purchase through the commercial market, governments, or actually in some cases, labor unions who contract with the PBMs. PBMs serve to lower the cost for those providing and paying for the benefit. It is by lowering these costs that the benefit provider or employer can pass the savings on to their employees, who are the patients. In that light, I want to point out that just a couple of studies. The analytics firm IQVIA showed PBM tools, when PBM tools are used, the net spending in 2017 on prescription drugs declined by 2.1%, declined, as opposed to an increase of nearly 6% without PBM involvement. Now, PCMA believes that the provisions contained in sections 5 and 6 do nothing to lower the cost of prescription drug benefits, but rather pose potentially additional costs. For example, a more recent study conducted by the pharmacy consultant Visant and issued in April of this year estimated a fiduciary requirement such as would be imposed by section 5 of the bill would reduce savings, meaning more costly, from many PBM tools and add the necessity of costly liability insurance on the PBM. The report said in New Hampshire specifically, it estimates additional costs over the next 10 years of $245 million. Furthermore, on that subject, according to the Federal Department of Labor and ERISA and federal courts, PBMs are not fiduciaries as they have no power to make decisions on either plan policy or they have discretionary authority over plan assets. They just don't. And this concept has been kicking around in various states for close to 20 years now. In fact, in 2 jurisdictions where it passed, it was litigated. And I'm not sure that that's the road that we want to head down. The cost of prescription drugs, in summary, cannot be lowered by making it more expensive for people who pay the premiums. And much of sections 5 and 6 have already been addressed in recent legislation where the stakeholders came together, worked on solutions to problems that met the needs of all. In other words, we were keeping in place the cost savings measures.
I'm sorry, Senator Kavanaugh, that's 3 minutes.
I'll simply wrap up.
If you could just wrap up, that'd be great.
Thank you. I'll just echo what Mr. Funstein said on behalf of AHIP earlier, that prescription drug prices start with the manufacturer list price. And it's my hope that we can strike sections 5 and 6, and PCMA is okay with the P&T committee proposal that Senator Bradley presented. Thank you.
Thank you, sir. Are there any questions from the committee? Seeing none, thank you. Tricia, if you can call the next speaker.
Yes. Okay, our next speaker is Lindsay Nadeau. Ms. Nadeau, you are able to talk.
Thank you. Good morning. Thank you, Mr. Chairman and committee members. I will keep this brief because I was lucky enough to have others go before me. I am Lindsay Nadeau from Orrin Reno, appearing on behalf of Cigna. And I would just like to reiterate that we share the comments that have been made by AHIP as well as the comments you just heard from PCMA. We appreciate your time and work on the bills that have been put into this amendment, as well as the opportunity to keep working with stakeholders to revise the amendment. And again, we just would reiterate that we would be supportive of the comments from AHIP and PCMA and are supportive of the amendment from Senator Bradley that you heard about earlier. And with that, I'm happy to take any questions.
Thank you, Ms. Nadeau. Are there any questions from the committee? Seeing none, thank you. Tricia, if you could call the next speaker, please.
Yes, Senator, next we have Catherine Cole. Ms. Cole, you should be able to speak.
Hi, good morning. My name is Katie Cole, and I'm here to testify on behalf of Tufts Health Freedom Plan in support of Senator Bradley's amendment. We appreciate the opportunity to testify today, and I'd like to thank Senator Bradley, Senate President Susie, and the committee for their hard work on this issue. By way of background, Tufts Health Plan serves more than 1 million members throughout New England and over 40,000 New Hampshire residents through Tufts Health Freedom Plan. Freedom is a unique partnership between Tufts Health Plan and Granite Health, which consists of 5 of the largest independent value-based healthcare systems in New Hampshire. Senator Bradley's amendment makes important changes to the original legislation by capping the total amount a covered person is required to pay for covered prescription insulin drugs at an amount not to exceed $50 per prescription. Based on feedback from our pharmacy department, this change is important as some members use multiple types of insulin and may get more than one 30-day dispense per month due to early refills. It's industry standard to allow refills when members use about 80% of their supply. So members who get a 30-day refills can refill about every 24 days. We don't want our members to run out. So administratively, the feedback I received is much less burdensome to apply the copay cap per prescription versus tracking multiple drugs to meet a $100 cap. So for members with 2 prescriptions, they would still be meeting the $100 maximum copayment with the 2 $50 copays if applied to each prescription. Senator Bradley's amendment also makes important changes to the section on prior authorizations that by stipulating that carriers would have 2 business days. This is important just to make sure that there's enough time if a PA request comes in on a Friday afternoon, for example, that the carrier would have enough time to respond. As Senator Bradley mentioned, there is already a statute that exists that allows a covered person to obtain a 72-hour emergency supply of a prescription drug if it requires PA. So I think with the 2 business day language and the 72-hour emergency supply language that's already on the books, I think we can make sure that no members would ever go without a necessary prescription drug. And then lastly, his amendment makes changes to the section around pharmacy and therapeutics committee membership to be more in line with federal guidelines around this issue that we currently follow. So with that, I wanted to keep my comments brief. Thank you for your time, and I'm happy to answer any questions.
Thank you, Ms. Cole. Are there any questions from the committee members?
Mr. Chairman, may I ask a question?
Sure. Senator Su.
Thank you. Ms. Cole, I just want to make sure I understood your testimony. Could you just repeat the portion about the cap on prescriptions and how that impacts people that have more than 1 prescription?
Sure. So the feedback that we received from our pharmacy team is that administratively, it is much easier to cap per prescription versus having multiple prescriptions that would apply to an overall cap. So for example, many of our members have more than 1 insulin type. So for each insulin type, administratively to apply a $50 cap, for example, as written in Senator Bradley's amendment, is much easier to apply per prescription versus an overall cap. So that's just the feedback that we received.
Thank you.
You're welcome.
Are there any more questions from the committee? Seeing none, Tricia, if you can call the next speaker, please. Trish, you're on mute.
Trish, we can't hear you.
Tricia, you're on mute.
And I think she froze
Looks
up.
like she froze.
All right, I'll step in.
You're on mute, Cam.
Cam, you went on mute too.
There we go. Sorry. It looks like the next speaker is Roxy Kazichik. I'm sorry for mispronouncing your last name, but you should be able to speak now.
Thank you. Good morning to the committee, and thank you for the opportunity to speak. My name is Roxy Kazichik, so close. I'm the Director of State Government Affairs for the Healthcare Distribution Alliance, HDA. HDA is the national trade association that represents the nation's primary pharmaceutical wholesale distributors. Wholesale distributors serve as the critical logistics providers, and HDA members work 24 hours a day, 365 days a year to ensure that 15 million healthcare products a day are delivered to more than 200,000 pharmacies, hospitals, nursing homes, and other healthcare settings and points of care nationwide. I know that the committee has received my testimony, so I'll be brief and mindful of the time and kind of cut to the chase here. So I want to be clear that we don't oppose the amendment to House Bill 1280. We just respectfully request a few technical changes to sections 9 and 11. We appreciate that the committee is willing to work on our concerns and have expressed that. So we just would like to point to the fact that HDA does not oppose the Drug Affordability Board and the efforts that that board has to addressing high drug prices in Section 9. But in order to make the disclosures and notifications provision work for our industry, we have a few suggestions that we think would actually help with the intent of the bill. Most specifically, I would point to the section regarding fees. Referenced in Section 9, I believe it's in 126 BB9 Section 3D. We would ask that those exclude bona fide service fees. Wholesale distributors charge manufacturers distribution fees related to their services that they provide, such as packing, shipping, transit, etc. So these do not relate to the price of a drug, nor are they passed along to downstream customers. The bona fide service fee exclusion from price metrics is in federal code. So we feel if this is going to be included in this portion of the section, it should reflect what federal CMS has determined in its rulemakings. And we think this would be a more accurate reflection of what you are looking for from us. Secondly, we would also in Section 9 ask for the strengthening of the audit language. We think that there's some fixes to be made that would strengthen the language to the effect that it would provide reasonable cause for the state to go in and audit licensees and require some reasonable notification in advance of any such audit. And then we would also ask for a clarification of the definition of manufacturer in Section 9 as well. And like I said, the committee has the full comments, and so feel free to ask questions after my remarks if you have those. And then finally, HDA also has.
I'm sorry, Senator Kavanaugh, that's 3 minutes.
Okay, I will be wrapping up shortly. And then lastly, in Section 11, we would ask some clarity around how the state is trying to determine and strengthen its consumer protection regarding price gouging of generic drugs. And again, the committee has HDA's full suggestion for that. So with that, I'd like to thank the committee again, and hopefully we can work work together to agree on some of these technical changes we think would advance the intent of the amendment. So thank you, and I'll take any questions.
Okay, thank you for your testimony and wrapping that up. I appreciate it. Are there any questions from the committee? Seeing none, thank you for your testimony. And Tricia,
thank you.
Back, Cam filled in
okay.
for you. And if you could call the next speaker, thank you.
Yes. Okay. Let's see. Next, we have Jody Grimless. Let me just pull her up. Ms. Grimless, you should be able to speak now.
Great. Can you hear me?
Yes.
Thank you very much. I'll be. Thank you all for inviting us to this committee hearing. Thank you specifically to Senate President Donna Soucy and Senator Bradley for continuing the consensus. The only things I'd like to speak to, and I'll be very brief because they've already been raised, was the concern. I represent CVS Health, specific to Senate Bill 686 being included in the committee amendment, specifically sections 5 and 6. There was a section of Senate Bill 686 relative to the reverse auction. We take no position on that. That is Section 7. So we have no concern about Section 7. Our primary concern is Sections 5 and 6. We oppose the new PBM regulations in the original Senate hearing. They were not part of a consensus as it came out of the Senate floor. We believe these issues would be better suited for the 2021 session. Are happy to work with sponsors and supporters over the fall to go through each provision of a very comprehensive bill that raised multiple major policy provisions. And so we'd like to have that opportunity. We believe several of the issues have already been addressed in New Hampshire law, and they're created a lot of confusion and cost implications. Senator Bradley testified to an amendment this morning that removes Section 5 and 6 and replaces it with new the Therapeutics Committee. We can support that. We can certainly accept that position. And finally, last law on regulating PBMs and the Department of Insurance is moving forward swiftly and actually is before GELCAR today with the final regulations. So those pieces are also moving forward. I think probably this morning if it hasn't happened already. So again, thank you very much for the time. We're looking forward to working with anybody to continue the conversation and make sure we can get to that consensus piece of legislation that you're all looking for. Thank you.
Thank you, Ms. Grimbles, for your testimony. Are there any questions from the committee members? Seeing none, thank you for your testimony. And Tricia?
Yes. Senator, we have former Senator Peter Bragdon. Former Senator Bragdon, you should be able to speak now.
Great, thank you very much. Thank you, Mr. Chairman, members of the committee. Peter Bragdon, representing Harvard Pilgrim Healthcare, the state's largest not-for-profit health insurance carrier. Here supporting the amendment proposed by Senator Bradley. I thank Senator Bradley and Senator Soucy for continuing to talk about this bill and the amendment, and the committee members for trying to make this a bipartisan proposal coming forward. We had some concerns on the amendment that was in the House calendar and are supportive of the proposal by Senator Bradley that helps alleviate some of those concerns. There's a couple specific things. I think I would agree with the prior statement from Katie at Tufts about the logistics and the mechanics of making the insulin cap work, and it's certainly a lot easier on a per prescription basis than tracking activity in a different way. And then also Section 12 of the bill, which has to do with the prior authorizations. In addition to the 2 business day issue, there's language in that basically starts the clock ticking on the submission of what's basically a completed request. Right now, it just says a request is submitted, and obviously we'd like the clock to start if a complete request is received, and if it's missing information, then don't want to be run afoul of the law by needing more information on there. So the language there is indicative of what would be a complete request. And then finally, Section 19 of the bill, I scoured all the other bills that have been discussed this year. I could not find Section 19 in any other bill. And it seems like it would increase the cost of prescription drugs for consumers by taking away one of the lowest cost options on that tier. And I don't know where that extra money goes, but it doesn't stay with the consumer. So we have a concern about that. That wasn't part of Senator Bradley's amendment. Others have mentioned it, and Harvard would concur that that's an issue. So appreciate all the work you're doing in these difficult times, and happy to answer any questions. Thank you very much.
Thank you, Senator Bragdon, for your testimony. Are there any questions from the committee? Seeing none, thank you, Senator, for your testimony.
You're welcome.
Tricia, if you could call the next speaker, please.
Okay, we have one more speaker, Senator, and that is Mr. Rick Newman. I do not see him signed in yet. I'm just going to check the list. Mr. Newman, if you're on, could you please raise your hand?
If he's on the phone, he can do, is it *9, I believe?
Yes, if you're on the phone, you can hit *9 and your virtual hand will raise.
Also, we have Paul Rogers raising her hand who might.
Oh, and I have somebody raising their hand. Is this Mr. Newman?
Yes, it is.
Okay, you're free to talk now. Thank you.
Thank you, Mr. Chairman and members of the committee. Rick Newman, representing the New Hampshire Independent Pharmacy Association. I wanted to address very quickly Section 19 that has been raised by the Department of Insurance. The Department of Insurance made the point to you that it is the legislature that makes policy, and they are absolutely correct, and we agree with that. This section creates the policy of what exactly is a contracted co-payment. This debate has been going on for years. The legislature has adopted several laws to address this, and every time they do, the department adopts a rule that is contrary to what the legislature has done. They've done it again today in an administrative rule that's in GELCAR today. They define a contracted co-payment differently than this language. This language says just exactly what a contracted co-payment is. It is the amount of money that's on your insurance card. It says you pay the pharmacy. What the PBMs have been doing is using the Department of Insurance definition. Let's just say that a customer's copay is $20, they pay the pharmacy $20. The PBM then comes in and says, oh, well, the maximum allowable cost on that is $10. So we want you to give us back $10. They don't say give it back to the consumer. They say give it back to us, to the PBM. This will solve that problem. As to the Department of Insurance's claim that this will increase cost to the consumer, I would point out to the committee two things. One, there's a current law that says that the pharmacy shall charge their usual and customary price or the contracted copay, whichever is lower. That is current law. Secondly, in this amendment, 402(2), paragraph 4, 402:2, paragraph 4, sets in place safeguards to make sure that the consumer is getting the lowest price possible. So the argument that this is anti-consumer is simply false. This is a section put in there to keep PBMs from taking money from consumers' pockets. I would urge you to keep it in there. Otherwise, New Hampshire Independent Pharmacy supports the amendment before you. Thank you.
Thank you, Mr. Newman. Is there any questions from the committee members? Seeing none, thank you for your testimony. Tricia, do we have another speaker?
Yes, actually, we have two hands raised, Senator. So first is Paula Rogers. Ms. Rogers, you should be able to speak.
Yes, good morning. Thank you very much for noticing my raised hand.
Sure.
For the record, I'm Paula Rogers and I represent Anthem. And I wanted to let the panel know that Anthem is a member of both AHIP and PMCA. And PCMA, I should say. So what I wanted to do was skip very quickly through the bill because a lot has been said. And so I'm going to start with the first 4 sections, which are the insulin related sections. The insulin bill had a very, very extensive hearing in House Commerce. And it was during that hearing that I think carriers said, you know what, there's got to be an adjustment made. And so that kind of discussion went forward in the Commerce Committee, and where there was a difference of opinion was on the very thing you've been discussing. Is it going to be a monthly cap or is it going to be a per script cap? And you've heard the other carriers mention this. It is much more administratively comfortable for the plans to have a per script cap. And I looked at the Bradley amendment and it says that cap would cover any prescription during a month. So while there are always going to be gaps somewhere that need to be addressed, but I think this Bradley's amendment, Senator Bradley's amendment, really does the right thing. And I guess the remaining question is, if that's acceptable to the committee at large, what about the effective date? And I've heard 1 year out, half a year out, January 1, 2021, and I've heard 60 days. Obviously, plans prefer an opportunity to get administratively aligned because they have a number of things that they have to do after a legislative session. If this is an extenuating circumstance and the committee feels they need to be earlier than that, certainly 90 days would be preferable, but I've also heard 60 mentioned. So let's continue talking about that. The last thing I want to show is that I think the insulin coverage here in New Hampshire does one thing that other states haven't done, or not all of them have done, which is a complete protection from deductible. So that is a very, very substantial level of assistance. And I think it's important to go forward and get it done as soon as possible. That being said, we would prefer some lead time before an effective date on it. I'm going to skip over section 5 and 6 and come back to it. But on the other end of the bill, I'm not going to get into the argument between Rick Newman and Tyler Brannon. I've seen them go at this very issue in person, so it's a long-standing debate. I know less about it today than actually, knowing less about it is a good place to find myself, but I had circled 19 saying, what is this? And so, you know, ordinarily I would defer to the regulator, but I heard Rick as well, so I'll think about what he had to say. But getting back to prior auth, I think change there is absolutely important. There's also a prior auth on the books about exception process, i.e. when a drug isn't on a formulary. So this is now going to be amended to mirror that. So
Sorry, Senator Kavanaugh, that's 3 minutes.
That was 3 minutes. Okay, 5 and 6, one last thing. I'm picking up on Representative Butler. There was supposed to be a 2-year commission, a pharmacy commission, Senate Bill 226. The issues in 5 and 6 are really issues that should be for that commission. It met 3 times and then it went fallow in October of 2019. So we need to revive that. And so that's why 5 and 6 should be set aside. And that's what Senator Bradley does in his amendment. So thank you very much.
Thank you, Ms. Rogers, for your testimony. Are there any questions from the committee? Seeing none, thank you for your testimony. Tricia, if there's another speaker, please.
Yes, we have 2 more hands raised. We have Holly Stevens. Ms. Stevens?
Thank you for allowing me just to briefly speak again. Holly Stevens, Health Policy Coordinator at New Futures. Shame on me for not reading this completely and totally word for word, but I just wanted to give you the consumer perspective of Section 19. And we fall squarely in the Tyler Brannon camp. This would increase the cost to consumers out of pocket. There are many times that people go to the pharmacy, and if you ever go to the pharmacy and your copay is $3.34, and that's not one of your co-payments, that's because that's what the contracted rate was that your health carrier negotiated with the pharmacy. If the pharmacy was to charge you that $10 copay, that means that they could pocket that extra $6 and some odd cents. It does not generally go back to the PBM. It goes to the pharmacies or to the PBM, depending on what their relationship is. But either way, it doesn't stay with the consumer. So New Futures would also urge you to take a close look at Section 19, how it will impact people's out-of-pocket payments, and consider striking it. Thank you for your time. I apologize for having to speak twice on this.
Thank you. Tricia, can you call the next speaker, please?
Yes. The last speaker with a hand raised is former Senator Peter Bragdon.
And thank you, Mr. Chairman, for allowing me to speak a second time. This will be brief after I heard further discussion of Section 19. I would just say that this is obviously very complex, an ongoing battle. This particular section did not appear in any House bill or any Senate bill. And I think it's really unfair for it to pop up, with less than a week to go in the session. So this should probably be put off for a fuller discussion in the next legislative session. Thank you very much.
Thank you. Excuse me. Thank you, Senator. Tricia, are there any more speakers?
I do not have any other speakers registered or hands raised, Senator.
Okay, I'm going to ask again if there's any members of the public wishing to speak. I'll give you a couple moments to either jump on our chat room or raise your hand.
And again, if you're on the phone, you can raise your hand by pressing *9.
Thank you, Alan.
I do not see any hands raised.
Okay, are there any questions from the committee members or? Seeing none, I'd like to close the public hearing on Amendment 1298S. It looks like we do have some work still on both of these, and I think we can still meet next week and hopefully get these. Aaron, you can get the committee report out to everyone.
I will. Yep.
Hopefully we can get all the changes in there, and I'll send an email out, or Aaron, if you could send it out to the members today is good for everyone. Maybe even earlier in the week would be good. We'll take a kind of feel where everyone's schedule is like, and we'll call back the Commerce Committee to hopefully exact these two, the bill and the amendment. Are there any other questions or comments from the committee members?
Mr. Chairman.
Chairman, it's Senator.
Go ahead,
Go
Senator.
ahead, Madam President.
No, I
Senator
was
Susie, why don't you go, then we'll get Senator Morse.
just real quick, I was just going to ask that any of the written submissions be attached to the committee report so we can review those in conjunction with the committee report and understand where the amendment proposals were requested.
Okay, thank you. And Aaron, you've got that, right?
Yeah.
Great, thank you. Senator Morse.
Yeah, I just would like to comment on the efforts that have been going on. I don't, this is meant to be a bipartisan solution. That's certainly what's been worked on for almost 2 weeks now. To suggest that Senator Bradley French and Morse are the ones that are holding it up, I think is wrong. I think we're working with the Senate President, and she's working with a lot of other people to come to a solution that we can all vote on. There's a lot of legislation in this bill. We certainly want it to become positive. You know, if we have to pull something out because it's going to be, you know, not be a bipartisan vote, I guess we have to do that. But the reality is, I think we're 90% there, and I think we should keep working. And there's been a lot of work that's gone on to get to this point, and I think the Senate's doing a great job getting there.
Thank you, Senator. I do agree with that as well. Are there any other comments from the committee members? Seeing none, thank you. And I just want to say the same thing. I know a lot of people are doing a lot of work, and it's been a lot of conversations and a lot of work, emails and texts going on, and I appreciate everything everyone's doing, because it is crazy times, and the way we're communicating is totally different. So it's I do appreciate everyone on the committee and leadership from both sides that are really getting together to try to pull this together. I'd also like to thank Tricia, Cam, Aaron, Alan, and Deb. Again, to piggyback on Senator Bradley's comments, you guys pull this all together for us, and we really appreciate all the work you're doing, and any kind of keep this running smooth. So I really appreciate it.
Thank you.
So again, any more comments from the committee? So do I need a motion to adjourn?
So moved.
Okay, motion from Senator Moore, second by Senator Susie. I say yes. Senator Morgan?
Yes.
Senator Susie?
Yes.
Senator Morse?
Yes.
Senator French?
Yes.
Okay, well, thank you very much, everyone. We'll see you next week, and we'll get that email out to coordinate our schedules, and have a great weekend, everyone. We'll see you next week.
You as well, Mr. Chairman. That was good.